I prefer SGLT2I will be spoken by Dr. R. Hariharakrishnan sir, MD Internal Medicine, DM Cardio, Assistant Professor of Cardiology, Tamil Nadu Multi-Super Speciality Hospital, former Assistant Professor of Medicine at Government Thuthukudi Medical College and member of Cardiological Society of India.
Good morning to all. First of all, I would like to thank the organizers and my mentor, Professor Dr. Arulraj sir, for giving me this opportunity. So the topic today is diabetic heart failure. I prefer SGLT2. So this is the overview of today's talk: introduction, mechanisms, evidence, guidelines, and take-home message. So as my previous speaker, Professor Manoria sir, clearly explained, the new universal definition of heart failure classified heart failure into 4 categories. The 3 major categories: one is heart failure with reduced ejection fraction, where the EF is less than 40. If the EF is between 40 to 50, the heart failure with mid-range or mildly reduced ejection fraction. And third one is HFpEF, which is the most important topic now, with ejection fraction of more than 50%. The addition to this is the new one, heart failure with improved ejection fraction. So these are all the 4 major pillars of heart failure with reduced ejection fraction. As our previous speaker clearly explained, beta blocker, MRA, ARNI and SGLT2, these are the 4 pillars. If you use the quadruple therapy, the cardiovascular benefits and mortality benefits are maximum with the use of quadruple therapy. So this is the mechanisms by which SGLT2 inhibition offers cardiovascular benefits. We all know the preload reduction and afterload reduction. The most important mechanism is the direct myocardial effects. In preload reduction, the major important mechanism is by means of osmotic diuresis, and this is the one class of drugs which reduces the interstitial fluid volume. So it is most important in preload reduction. Then it will, in afterload reduction, it is mainly through the improvement of endothelial function and decrease in the vascular arterial stiffness. But the most important mechanism is the direct myocardial effects by means of metabolic efficiency, by shifting the cardiac metabolism from the glucose and fatty acid towards ketones. And it will improve the diastolic relaxation and the myocardial contraction by means of calcium homeostasis by inhibiting the sodium-potassium exchange. It will reduce the LV hypertrophy and remodeling. These are the slides shows the various mechanisms. So coming to the evidence of medicine, starts with the embotrophism trial, which showed the SGLT2 inhibition improves LV ejection fraction. It will improve LV ejection fraction and it will reduce the LV mass and it improves the myocardial oxygen consumption and 6-minute walk test. And also the SGLT2 inhibition offers reduction in LV volumes, especially N diastolic and N systolic volume significantly. These are all the pathognomonic parameters of heart failure pathology, but it can be assessed by the cardiac MR. So by reducing these both, this offers greater benefits. This meta-analysis from the Lancet showed the heart failure benefits by the SGLT2 inhibition, not only in patients with history of heart failure, also in patients with no history of heart failure. That is, patient at risk for heart failure also showed greater cardiovascular benefits with the use of SGLT2 inhibitors. So this is a major trial, empiric outcome trial, which showed SGLT2 inhibition offers greater cardiovascular mortality reduction and heart failure hospitalization not in patients with diabetes and established cardiovascular disease. There's almost 38% reduction in mortality reduction in patients with diabetes and cardiovascular disease. This benefits is more pronounced in Asian population. In the subgroup analysis, it showed almost 56% reduction in heart failure hospitalization. So this slide shows this is the class of drugs. SGLT2 inhibitors showed cardiovascular benefits in all the subgroups of heart failure. That is, starting from patients at risk for heart failure, likely diabetic, hypertensive, CKD and obesity. From there, patients with diabetes and cardiovascular disease, then heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and heart failure with reduced ejection fraction. In all the subgroups, these are all the only class of drugs showed cardiovascular benefits. This is the various cardiovascular outcome trials showed greater cardiovascular mortality benefit in heart failure and diabetes. So this is the class effect. It is not belonging to the single drug. All the drugs, empagliflozin, canagliflozin, dapagliflozin, and etugliflozin, all the drugs showed significant mortality benefits. These are all the two major trials, Emperor reduced and DAPA-HF, which showed in patients with heart failure with the reduced ejection fraction, there is a significant cardiovascular mortality benefit, significant reduction in heart failure hospitalization. In both trials, clearly explain the cardiovascular benefits irrespective of the diabetes status. Both in diabetic and non-diabetic population, the benefits are same. So coming to the most important topic, HFpEF. This is the most important topic because patients with diabetes and hypertension are more commonly present with HFpEF. So far there is no single class of drug offered mortality, cardiovascular mortality benefit in HFpEF. So this is the only class of drugs, SGLT2 inhibition offers cardiovascular mortality benefit in HFpEF. This is the major trial which used empagliflozin 10 mg, which showed significant almost 21% risk reduction in cardiovascular mortality and 27% risk reduction in heart failure hospitalization. Above all, it also showed better renal protection by declining the rate of GFR, by slowing the rate of decline in GFR. So it will reduce the progression to renal dysfunction. Even though there is an initial dip in eGFR, over the period it offers greater renal protection. So this slide shows SGLT2 inhibitors offers greater cardiovascular mortality benefit in both group of heart failure, both in heart failure with reduced ejection fraction and HFpEF. In both the groups, the benefits are significant. Mortality reduction, heart failure hospitalization, rehospitalization, and time to cardiovascular death. All the parameters significantly reduced in both group of heart failures. So this is the recent trial published in September 2022, ESC DELIVER trial, which also reiterate the effect of SGLT2 inhibition and benefits in HFpEF population. The conclusion is DAPA significantly reduced the risk of worsening heart failure and CV mortality and almost 18%. There is no excess of adverse events. That is most important. And these effects are irrespective of the diabetes or ejection fraction. And in CKD population, these class of drugs showed greater cardiovascular mortality benefit and hospitalization benefits, almost 29% risk reduction in CKD population. This is also unique for this group of drugs. So the DAPA will reduce the progression to renal dysfunction and slowing the rate of decline in GGFR. So these are all the various recommendations. Already our previous speaker clearly showed all this. Both ESC, ADA, Heart Failure, Canadian Association, all the associations showed SGLT2 inhibitors is a class 1 recommendation in patients with the diabetes and established CVD. And also these drugs are approved in diabetes with patients with cardiovascular risk factor at risk for heart failure. Even without CVD and heart failure, these groups are mainly recommended in this group. These are the various recommendations. Coming to the take-home message, SGLT2 inhibition showed significant survival and mortality benefit in patients with heart failure with reduced ejection fraction, mid-range ejection fraction, and HFpEF population. So the benefits across all the subgroups of heart failure, and these benefits irrespective of the diabetes status, both diabetic and non-diabetic population, and significant mortality reduction in patients with diabetes and established CVD, and also significant benefits in diabetes with at risk for heart failure patients. And in diabetic heart failure, there is significant reduction in declining renal function also. This is unique to this class of drugs. So the final slide, why I prefer SGL2 in diabetic heart failure. So the cardiovascular benefits across all the subsets of heart failure group. This is the only class of drugs which offers benefits in all the subgroups. And the benefits are irrespective of ejection fraction. Even in patients with EF of more than 60, it offers cardiovascular benefits. And the most important thing is there is no hemodynamic compromise, no significant hypotension. So we can safely initiate this molecule in acute decompensated heart failure. It is safe in elderly and beneficial in heart failure with renal dysfunction, especially in cardiorenal syndrome. There is no excess hyperkalemia, once daily dosing, and there is no need for dose up titration. Above all, in diabetic heart failure, it offers greater diabetic control also. So thank you one and all for the patient listening. Thank you.
Thank you, sir. Now, I prefer ARNI will be spoken by Dr. Arun Ranganathan, sir, MBBS, MD, Internal Medicine, DM Cardio, Senior Assistant Professor, Department of Cardiology, Government Stanley Medical College, Chennai. DM Cardiology, MD General Medicine, postgraduate students teaching facility in Stanley Medical College for more than 9 years, more than 10 national and international publications. Welcome you, sir.
Respected Chairperson,